Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Tehreem Younus. Actually, I am presenting a case that I saw once 2 years back, and now he again came to us. So I thought that it's an interesting case. I think it was discussed 2 years back also, but because it has created a new turn, so I wanted to discuss it again. So I'm starting with the case 2 years back. So he was a 56-year-old gentleman who is an active smoker for past 25 years. He's known case of hypertension and dyslipidemia, non-compliant with medications for past 15 years. He presented to us 2 years back with angina class 3 for 3 months. On examination, the blood pressure was 150/90, pulse was 74 beats per minute regular, and the chest and cardiovascular examination was unremarkable. So all labs were within normal limit, and ECG was also showed normal sinus rhythm with no STT wave changes. 2T echocardiography showed ejection fraction of 60% with no regional wall motion abnormality. MPI scan at that time showed severe reversible ischemia in inferior, infraseptal, anteroapical, and posterolateral walls. So after all this, we advised a diagnostic coronary angiogram, and as you can see, it showed severe disease in the proximal course of circ, and it is cross-feeding RCA through epicardial collateral vessels. And there is critical disease in the proximal LAD also. The right system showed totally occluded RCA from the origin. So after this diagnostic coronary angiogram, we advised the patient to have a coronary artery bypass grafting, but in spite of aggressive counseling to him and his family, he declined having any surgery. So we decided to open our CTO RCA, as the MPI scan showed majorly ischemia in the inferior segments. So we calculated the Japanese CTO score that came out to be 4, and it showed that it is a difficult CTO to be done. So we attempted the integrate PCI to RCA, and we used first of all run through, then pilot 50, then we used up to Gaia 3rd, but we could not cross the CTO segment, so we abandoned the procedure, and we again counseled the patient and his family that it's better to have a cabbage, but they were insisted that we don't want to have any surgical procedure. So our options was to repeat integrated attempt at CTO RCA with double stick approach, and then do the PCI of LAD and circ, as they also have a critical and severe disease. So another was the retrograde approach to RCA CTO via good size epicardial collateral vessels that were coming from circ, and then followed by PCI to LAD and circ, and lastly first PCI to LAD and circ, and followed by retrograde PCI to RCA. So I'm sure experts will also have an opinion, so what we did was we did a double stick approach, and we used, as you can see, wires. We started with pilot 200, but as you can see, that wire has gone subintimally, so we abandoned the procedure. Then we attempted the retrograde approach. We used a 7 French BL for left and JR4 for right, and we tried to cross the epicardial collateral by Sion Black over Corsair 150. And then we used pilot 200 and tried to cross the distal cap of the CTO, but we were not successful. Then we used Gaia 2nd, and it successfully crossed the CTO segment. Then we exchanged with a longer wire, RG3 wire, and we then externalized it. And then after that, we integrately passed the run-through wire over OTW balloon, and we then pre-dilated with the semi-compliant balloon. And then we deployed 2 drug-eluting stents. They were 3 into 48 from proximal to mid-course, and then 3.5 into 28 from the ostium to the proximal course of RCA. So this is the final result of the right coronary system. After that, we also, in next session, we also fixed his LAD and circ. So interestingly, patient remained stable for past 2 years, and he had no symptoms or any complaints. After 2 years, he came again with angina class 1, 2 for 1 month. ECG, 2T echo were normal. Coro angio was done, which was also normal. MPI scan showed ejection fraction of 55% with mild fixed defect in the infraseptal wall, and the viability was 3/4. On taking the history, he just took medications for 6 months after CTO and the fixation of the left system, and he stopped taking all kind of medications after 6 months. He was already hypertensive dyslipidemic. He was not taking medications. Again, he stopped. After having 4 stents, he stopped taking medications, and he again came with angina. So we have started some aggressive medical management. We increased the dose of statins. We have asked him to have a compliance of medications. So we have seen this patient recently, so I just said that to share this. Yes, so it's important that after doing a CTO, we should counsel the patient for having a good compliance with medications. Sometimes it's not the technical problem, sometimes it's also the medical, patient are not taking their drugs optimally. So they came with again chest pain.
Great case. It's a little interesting.